Good evening. Extremely sorry. Extremely sorry. I'm late by 5 minutes.
Good evening, ma'am. It's okay, ma'am. We were
So
waiting for
sorry.
you. Pankaj Modi sir is already there.
Radha,
Atul
it's
sir and Suti
okay.
sir. So,
5 minutes is fine, absolutely fine. Don't feel
So
guilty.
sorry. So sorry, sir.
so ma'am, we have both our examiners here and everyone's here, so we can start now.
Should I
Yes, you
start?
can start.
Yeah, start, Chitri.
Okay. Good evening, everyone. Today I'll be presenting a case of peripheral vascular disease. So, a 65-year-old lady, housewife by occupation, resident of Sadar Bazar, Satara, came with chief complaints of pain in the right lower limb since 2 months and blackish discoloration of the right great toe since 1 month. The patient was apparently all right 2 months back when she first noticed pain in her right calf muscle while walking, which was cramping in nature and non radiating. The pain was insidious in onset and gradually progressive over 2 months. Initially, it increased after walking some distance and relieved after taking rest. At present, she is having constant, severe pain even on rest. She noticed the discoloration at first at the tip of her right great toe 1 month back, which gradually progressed to current extent involving the dorsal, medial, and plantar aspect of the right great toe. These are the pictures. There is no history of complaints on the other leg, no history of bluish discoloration or pallor on exposure to cold, no history of swelling or pain along the course of superficial veins of the leg, no history of trauma, no history of prolonged immobilization, no history of blurring of vision or loss of consciousness, no history of pain in abdomen, nausea, vomiting, no history of fever or foul smelling discharge, no history of burning or tingling sensation, no joint pain or skin rashes. uh, in the past history, there is no history of similar complaints in the past. She's a known case of diabetes and hypertension controlled on medication. There are no other comorbidities. There is no history of any intervention or operative procedure in the past. In personal history, she has history of misery or burnt tobacco powder chewing since 30 years. She has altered sleep due to pain since last 1 month and tends to sleep better in a chair. The patient has regular bowel bladder movement. She has a vegetarian diet. She is P2L2 with menopause achieved at the age of 52. There is no history of drug allergy and no significant family history. So my summary is that she's a 65-year-old lady, chronic misery tobacco chewer, known case of diabetes, hypertension, with rest pain and gangrene of right great toe, is most likely a case of chronic limb threatening ischemia. Should I proceed to the examination part?
Can we go back to history? No history of.
We'll
Can we
go
go
back.
back a little bit?
Yes.
Oh, here. 1 minute. The next slide. The next slide. The next one. Okay, so no history of blurring of vision, loss of consciousness, no history of abdominal pain. What are you indicating in this? What is the significance of this?
So, the negative history of blurring of vision, loss of consciousness, pain in abdomen was to rule out any other previous embolic events that might have occurred.
Okay. Why abdomen, nausea, vomiting? Can you specify, please?
So sudden pain in abdomen can be due to mesenteric ischemia, which can be due to some emboli that has migrated and lodged in the mesenteric vessels.
Blurring of vision,
Sorry, ma'am.
blurring of vision, loss of consciousness.
If the emboli goes at the retinal artery, or if there is some cerebral emboli, then that can give the history of blurring of vision or loss of consciousness.
Okay, so an acute phenomena, right? Okay. Then we can go back. Thank you.
Okay. Kshitija, go to first slide, please.
Yes.
Okay. So patient's complaint is only since 2 months.
Yes, sir.
Before that, patient was absolutely normal.
Yes.
Right. Okay. Next slide. Okay. So the pain in calf is only since 2 months, you want to say?
Yes, sir.
Okay. What type of pain it is?
The pain was cramping in nature.
Now, what do you call it?
Claudication, sir.
Intermittent claudication.
Intermittent.
Claudication is not a proper word. Why?
uh, because the patient experiences the pain on walking, and there is no pain when the patient is at rest initially. So
No, no, no. What is claudication?
How do
claudic-
you define claudication?
claudication is the intermittent uh, cramping kind of pain which patient experiences on walking, and is relieved on rest.
No, that is incomplete. So there are two actual part. One is a claudication and another is a intermittent claudication. Or the better word is vascular claudication. The word which should be used is a vascular claudication. Do you know any other type of claudication?
Sir, neurogenic claudication.
Neurogenic claudication, very good.
Due to, due to cause of neurogenic claudication?
the the vessels that supply the neurons, uh,
No, no, it has nothing to do
Not
to vessel.
neurons.
due to the compression of the nerves, there is uh,
So, limping limb and pain due to neurological cause.
yes,
That is a neurogenic claudication. So,
yes.
how will you differentiate between neurogenic and vascular?
Ischemic claudication.
Better
Neurology.
word. Yes, you can call it also.
uh, so the vascular claudication becomes more severe on walking, on exercises, and it
So,
becomes
it is present. More severe means it is present, then become on walking more severe. Do
uh,
not confuse. So let me answer you are confused. The point is that neurogenic, a patient will have a pain and limping on the first step
yes,
because it is usually due to either spinal problem, disc problem, nerve root involvement. So as soon as patient starts walking on the first or second step, there will be pain. Limping may be there. That is a neurogenic claudication. Whereas ischemic, vascular, intermittent claudication does not happen on the first step.
yes.
It appears after walking certain distance, which is known as
Claudication distance, sir.
claudication distance.
Yes.
Then, now as the madam has said, give the actual definition of intermittent or ischemic or vascular claudication. There is a that definite definition, we can call it. So it's a cramp-like pain occurring in the foot, calf, thigh, or gluteal region. It can be anywhere. After walking certain distance, which compel the patient to take rest. And after taking rest, patient is able to walk same distance again before the pain appear. That is what we call vascular claudication. It's a very typical here. You should know this definition when you are appearing in exam, which is very important.
Yes.
Why the pain
Where
appears?
is the word claudication being derived? Which language is it? Does it come from, and what is the literal meaning of it?
Ma'am, Claudius means to limp. There was a
Okay.
King Claudius who used to limp, and from that the
Latin thing. Latin.
Latin term has been derived.
You can proceed.
Yes, ma'am.
Hmm. So why there is intermittent claudication?
Uh, Due to walking, there is a release of metabolitic substance P, which causes pain. And initially, when the patient continues to walk, then the vascular stress is overcome, and the substance P is
Washed away.
uh,
Washed away.
washed away, and then the patient can continue walking in spite of the pain. Later on, once the the disease progresses, the it compels the patient to take rest, because due to pain the patient is unable to walk. And when it progresses further, the patient can feel pain even at.
Kshitija, what was the question? The question was why intermittent claudication occurs. I am not asking you grades of claudication, and you are describing the grades of claudication. Why intermittent claudication occurs?
um,
So
when,
basically agreed. P substance appears in all. Even
yes,
in a normal person, when he or she walks, there will be pain or cramp-like pain after certain walking.
yes,
Depends upon the person to person. Some can walk 5 kilometers, some can walk 1 kilometer, which we call as a physiological claudication.
yes.
So why there is intermittent claudication?
There is a inadequate supply compared to the demand of the
So
muscles.
it suggests early ischemia,
Yes,
right? Which gives rise to patient is unable to supply increased requirement of blood and nutrition when he walks.
yes, sir.
He takes rest, again able to walk the same. It
Yes,
depends upon the amount of collaterals. Sometimes if the collaterals are good, patient is able to walk with pain. Sometimes over the period of time, even as the collaterals get affected, patient claudication distance decreases and one day it occurs into critical ischemia, what we call as a rest pain. So understand the claudication parts, and usually the history of claudication is in year, not in a 2 month. Do you understand?
yes.
Right? When the patient gives his very short history with blackening, what will be your first thought?
Um, Sir, if the patient gives history of very short duration,
Right,
then it can be some acute phenomena, which
right.
is
Like, like,
like acute embolic event.
very
Uh,
good. One is embolism.
yes.
What
Uh,
is chronic embolism? You say
Chronic,
acute embolism.
yes, sir. Any thrombotic plaque can dislodge and cause thromboembolism. Any
So the word is chronic thrombosis, chronic or acute thrombosis. Embolism is almost always acute.
acute, yes,
Right? So there's nothing like chronic embolism.
yes,
Understand this. Right. So acute thrombosis, embolism, and trauma. These are the three conditions when the patient can have a very short history with development of vascular complaints. Right? So do
yes.
you think this patient has acute ischemia?
Sir, she was giving history of pain since 2 months, which
Mhm.
increased gradually. If she had given
Again, what did I ask you? Do you think it is acute ischemia or chronic ischemia? What is your thought from history?
um, from history,
Obviously, I
it,
don't know examination
yes,
except that
so,
photo.
yes, from history point of view, it appears like an
Yeah.
acute event, sir.
Madam, please. Hmm. Okay. So she noticed discoloration. When did she notice?
She noticed the discoloration 1 month ago.
1 month ago. Right? There is a one sentence, you are not elaborated it. Patient is having constant severe pain even on rest. Since how long that pain is there?
Since the past 8 days, she was having constant severe pain.
Do not mention it. Why it is important?
The constant severe pain, uh, the constant severe pain signifies that there is ischemia that is setting, and the nerves are affected, and that
So easy way out for a student is it is a classical rest pain.
yes,
These are the things which will be asked. Don't fall in traps. So
yes.
what is definition of rest?
Uh, Rest pain is a uh, constant sharp pain which is felt by the patient, and it is often called as the crying of the dying nurse.
That is not
Where is it
definition.
situated?
Yes.
So
The
can I
question
ask one thing? Where is it situated?
part. Yes, madam.
Where is it situated, Kshitija?
Sorry, ma'am, where is what situated?
The pain situated?
The pain is in
Rest
her
pain?
calf, ma'am.
Calf? Rest pain?
Sorry, ma'am.
Rest pain in the calf?
Madam is asking where this severe constant pain even on rest. You have not mentioned the place. That's what I was. You have not
Site
discussed
of
much
pain.
about this pain. Madam
The
is
site of
asking
pain.
where is it felt.
So the rest pain is uh, at the toe region.
Yes. And what type of pain? What is the characteristic of that pain?
It is a persistent, severe pain, which is like a sharp pin, pins and needles kind of pain.
Anything
No.
more? No,
Uh,
yeah, it's not right. Anything more? Think.
uh, it's a sharp
If you don't know, you say you
burning,
don't know.
sharp burning kind of pain.
Burning. Burn. So, Pankaj, sir.
Yes.
Sharp
So
burning,
by
tearing.
by definition, rest pain is constant, severe, burning pain in the distal part of the limb, compelling the patient to remain awake. Right? So, what does it suggest? Don't tell me the crying of dying now. What does the rest pain suggest?
Uh, that the ischemia of the muscles is setting in.
So, you are again confusing intermittent claudication with the rest pain. So if the muscle ischemia is setting in, why the blackening is at the toe? Madam has specifically asked for the same reason. Where the pain is there? It is which muscle is affecting, you want to say, in a rest pain? Remember, it's a pain of skin and subcutaneous tissue predominantly.
Yes.
Yes, it involves all part, but the predominantly. Muscles come late in picture. What does it suggest?
um,
It's a classical sign of critical ischemia.
yes.
What is critical ischemia?
uh, Critical limb ischemia, uh, it means that
Sorry.
there is a severe end stage disease.
Rest pain is a critical.
Hmm. So what does it suggest? It suggests limb is about to go black. It's a heralding sign of that.
Non-viability.
Yes, it will lead to that. That's why it is known as a critical limb ischemia or critical limb ischemia.
Which
You
nerves
sh-
are involved?
Uh,
Kshitija?
the C type of pain fibers of the nerves, ma'am.
Of the
The C type of pain nociceptors.
plantar nerves.
The sensory nerves of C type of
Okay.
nerve fibers.
Hmm. It's
How
a
does a patient find relief of from this rest pain? Not critically critical
hmm.
uh, in the initial phase. How does the patient find relief?
Uh, the patient finds relief on dangling the legs on a dependent part, which gives some relief
Okay.
on a dependent area.
Why so?
uh, due to uh, due to gravity, there is a pooling of blood, and there might be better better supply to the ischemic parts.
Better supply, or when the patient is sitting, the blood is accumulated over there. It's cut off at the knee level, right?
Yes, ma'am.
So is it right, Pankaj sir?
Yes, yes, madam. Carry on, please. I was just thinking. Seriously.
Carry on, Kshitija.
Yes, ma'am.
Okay. So, what madam wanted to ask, how the patient get relief? There are very typical features in presence of rest pain. One is dangling the limb by the side of the cot, holding the limb in a flex position, particularly foot he or she will hold in a tightened position. Do you understand? Patient will feel better when uncovered. If you try to cover the limb, patient will have a more pain. This all is related to pulling of blood and diluting the painful piece substance, which help the patient to have a lesser pain.
Yes.
Okay. So keep this thing in mind when we are talking and describe rest pain little more, because you have said about intermittent claudication.
Yes, ma'am.
Then the next step is rest pain, and then the third step is blackening. So looking from history is again my question is, you have said it is acute ischemia. So what are the symptoms of acute ischemia? Sign we will discuss later. What are the symptoms of acute ischemia?
uh,
But that you should be asking. You have asked about mesenteric, you ask all things. But what are the typical features of acute ischemia in a limb?
Sudden pain, and the other symptoms would be coldness of the limbs, and pallor in the limbs, the distal part of the limbs, and there would be loss of sensation, and loss of power.
Anything to do with hair?
uh,
Past hair.
in a chronic in a chronic setting, there can be loss of hair over the skin.
Yes. The point here is that there are five P's. You remember it like that,
Yes.
right? Pain, pulselessness, paresthesia, and so on. Pallor. Do you understand?
Yes.
Point is, so those are the acute ischemia. So why you are telling this acute ischemia? Out of all this, which one is present in your history?
Sir, pain is present,
Pain
and
will be there in chronic also,
yes.
but sudden origin. Usually, patient will come you pain of 24 hours or something like that.
Yes.
Hmm. Yes?
Yes.
Okay. You are because of short history, apart from short history, there is nothing again suggestive of chronic ischemia.
Acute. Yes.
Okay. Right. Next slide.
Why
Because the gangrene
tobacco?
part, yes, madam,
Sorry,
please.
ma'am.
Yes.
How does tobacco cause ischemia? What is the role of tobacco or mishri or whatever?
uh, the
How is it relevant?
tobacco chewing can cause chronic endothelial damage by the
Good.
toxins, and that can cause a development of systemic vascular diseases, which can promote the limb ischemias.
Good. The endothelial lining I wanted to hear. Fine.
Any other reason?
uh, it can also cause vasoconstriction, and uh, can Accelerate atherosclerosis.
Atherosclerosis, endothelial damage again, and on the lung, carbon monoxide toxicity, decreases
Pardon me.
the exchange of oxygen because of the deposition in lung, right? All these are universal features.
Yes.
So they same features apply when we are discussing thromboangiitis obliterans or Burgess disease. The
Yes.
cause is same or is there any other? Because invariably, if patient has a Burgess disease, tobacco exposure
Yes.
of persistent and long time is mandatory. Why? So it is the same principle apply there, or is there anything else?
Uh, so, sir, in systemic diseases where tobacco causes intimal damage, and Berger's disease, the part of the vessel that is affected, that differs. In Burgess disease, the majority of the damage is of the media, and the intima is relatively spared, as opposed to the intimal damage in the other systemic diseases,
Atherosclerosis.
like atherosclerosis.
Okay. So basically, large vessel, medium, small vessels. But remember, the specific reason is a Burgess disease is an autoimmune disease. How does it affect? It creates the autoimmune, what antigen antibody reaction inside the intima of the medium and small size vessel because of the tobacco protein which contains in the BD or a raw tobacco,
Yes.
which causes what is known as a cellular thrombus. So patient will have multiple sites thrombus. That's why it is known as angiitis, thrombo, and obliterans. These three parts are
Inflammation.
because of this. So that should be kept in a mind. It is a antigen antibody reaction which is, and that's why if somebody asks you why the cigarette smoker do not develop the TAO, what is the
Anything
reason?
different between BD and cigarette?
Madam has given you hint.
Shitija.
The filter,
Filter. Yes.
the
Processed tobacco,
yes.
which dilutes the tobacco protein in a cigarette and with filter less value. So that is the main reason. So you will never find anybody, cigarette smoker, having a TAO. They are exclusively BD. You know what is South Indian arthritis?
Sorry, sir.
There is a one severe variant of TAO found in South India when there is a sutta smoking, that is reverse
Reverse,
smoking.
reverse BD
Reverse.
smoke.
They take the burning part of BD inside mouth and smoke, and which expose them more. So it is a more severe variety. But anyway, this doesn't seems to be TO by any means. But just for the when you are mentioned tobacco, so when it is the atherosclerosis, the reasons are different. When it is TO, it is different. Right? Next.
What is the difference between thrombophlebitis and phlebothrombosis?
Thrombophlebitis is the inflammation of the uh, vessel, and phlebothrombosis means there is a thrombus present in the uh, vein.
Which is more dangerous, the phlebitis or thrombosis?
The phlebothrombosis is more dangerous because it can
Very
embolize.
good. And not why not phlebitis?
Sorry, ma'am.
Why not thrombophlebitis?
Thrombophlebitis is the swelling of the wall of the veins.
Basically, it is inflammation, and this is here. It can give rise to a
Embolus.
embolus.
Yes.
That's the
So
reason.
the madam is asking very specifically. So if I give you a more simpler version, the one is an inflammatory disease, another is degenerative organ. So when there is inflammation, there is a sticking and fibrosis. Well, reason is the DVT or part of DVT, which is forms the loose thrombus. Next. Okay, next. This will come when your examination.
Yes.
So you have written so many things, madam has already discussed. No, go back, past history.
Yes.
नहीं, past, हाँ. So how did you, this is just to, well, why did you write control on medication? How did you decide that it is control?
Um, so her HB even The diabetic control.
So patient has come in exam with the report.
No, sir.
You understand?
Yes,
Though
sir.
it is a small point, doesn't make difference here. I understand your point, but don't speak it.
Yes, yes,
Right?
yes,
Means, yes, some educated person is there, that's fine. But most of them, a patient is a known case of diabetes and hypertension. What I will be more interested, since how long?
yes.
Since how long?
Since 30 years, sir.
So that should be more important. You should have written. So what
Yes.
is significance of that? 30 years diabetes and 30 years hypertension
Uh,
in
Chronic.
related to vascular disease.
Uh, the prolonged diabetes can cause the macro and micro vasculopathies and neuropathies that are related to the progression of the disease.
So
And
here patient is 70 year of age and
yes,
appearance of vascular, you should say it has hastens the atherosclerosis.
yes,
Diabetic affect two way. One is a micro, you have said. Second is a
macro.
it directly affect the early presentation or the severe presentation of atherosclerosis. Again, because that's why you have asked all these histories,
Yes.
abdominal and that. And
How does diabetes? How does diabetes affect? How does what is how does it affect? What is the pathology diabetes can cause? The nerves, arteries, and
The nerves, arteries, and the increased sugar content in the vasculature. It can cause infections. There can be micro and macro angiopathies and neuropathy. The neuropathies.
and peripheral neuropathy.
Yes.
What is the pathophysiology of which column is affected in peripheral neuropathy?
Sorry, ma'am.
Okay, posterior. Read about it. Next. सर बोलेंगे मैं यहाँ अटक गई हूँ. पंकज sir. Continue, Kshitija.
Yes, ma'am. Uh, shall I go on to the examination part?
What was it? Intervention? No history of any intervention of what? No
Uh,
history of intervention.
I meant no surgical procedure or no operative procedure was done
Okay.
for her in the past. Shall I go on to the examination part?
Yeah, yeah, please do. Please do.
I'm asking you which procedure you expected in history in this patient. So suppose patient gives history of appendicectomy. It is of no significance. You say intervention. Which intervention? Usually such patient will have either angioplasty done in such patients or angiography was done. So that
Yes.
is the procedure. You should know
Yes.
what is that, because in relation to that, there may be so many history of surgeries and that, but they are not important. The
Yes.
important is related to disease,
Yes.
right? What
Yes.
do you mean? No other comorbidities in past history? Not needed.
Not. Yes.
Do not write down.
Yes.
Why do you, this the first I did not want to discuss, but anyway, what do you mean by no history of similar complaint in past?
Um, there was no history of leg pain in the past.
So suppose patient gives history of leg pain before 2 years. How is it significant? So remember, this is vascular case.
Yes.
Once patient had a similar complaint before 2 years, her history starts since 2 years.
Yes.
It is not a past history.
Yes.
Do you understand? It does not remain past history. That's what I wanted to say. So
Yes.
simply known case of diabetes and hypertension is 30 years.
Yes.
And maybe intervention part is okay. So understand this point, which is very important.
Yes.
When you say similar complaint of leg in past, that becomes a present history.
Yes.
There may be intermittent claudication since 2 years,
Yes.
which you are taking it as a past history. Because just for the completion, I would say many patients will come. This is the ideal case you have got. But many patients has amputation on opposite side for the same complaint. So will you take it in past history or present history?
Yes. Present history, sir.
Hmm?
Yes.
Yes means what?
Yeah, in the present history, sir.
In the present history.
Yes.
So your history starts long back. That is the importance of vascular. Same limb, many times patient will come with amputation before 1 year. Then in between patient was all right. Not much of a pain. And then again present with the blackening. This is very common patients you will get. So they all become part of a present history. You understand? You
Yes.
will see a patient who has a bilateral amputation. Those cases can come like that, right? In
Yes.
a, have you written anything about any complaint in upper limb?
There was no complaints in the upper
But
limb.
have you written, talked about it?
I have mentioned it that there was no complaints in the other leg.
Other leg, no. I am talking of upper limb.
I think she mentioned something about Reynolds, right?
Uh,
Did
Yes, yes.
you? In the
I mentioned on exposure to cold there was a
no, I am not talking about. There can be intermittent claudication in upper limb. There
yes,
can be severe pain in upper limb also. But
yes,
yes, Raynaud's is fine. But you should also mention about upper limb.
yes.
Why did you mention that opposite leg? Rather limb. Leg is not a proper word. I would say opposite limb. Why? No, you're right, absolutely right. But why? I'm asking the reason. Why you said about oil?
So if there is involvement of the other leg, then we can
Other limb.
other limb. Sorry, if there is involvement of the other limb, then uh, we can postulate that the disease is more proximal in the larger vessels.
Very good. Great.
very good.
Very good. That's what answer. But more proper answer is as the patient is of 70 year of age.
Yes,
You understand? Has a history suggestive of 2 months or more,
yes,
likely to have atherosclerosis, which can be affecting the aorta or major vessels, which may produce the symptoms and signs on opposite limb. Right. You are right. Your thinking was perfect. Great. Next.
I'll go to the examination part, sir.
Okay.
Ma'am?
Naini, summary. I have something to talk about
Yes.
summary. What do you mean by limb threatening ischemia?
uh, as the patient currently has
Naini, what I want to ask you is patient has already got a black limb.
yes, sir.
What more threatening ischemia can be there? Do you understand? You
If
should
there
write chronic limb gangrene. It is not now ischemia. Limb may be ischemic, but gangrene has already set in. The threat is already there, which is fulfilled. So don't write down threatening.
yes,
Threatening is when the patient does not have any blackening. There may be a chronic ulcer, there can be a redness, brittle nail. You can write down threatening, but best part, threatening chronic limb
That is
ischemia.
uncalled for,
Ah,
threatening.
threatening is not a word, means
It's
some
already
examiner will
ischemia,
catch you
right?
there.
yes,
Do you understand? And
yes, sir.
our aim in exam is to pass.
Yes,
Should come out and do not use controversial words. That's it. Do you understand?
yes,
Right. You may be right, it's a diabetic is control. Agreed. You might have seen the report. I am not contesting. I am contesting that you are not supposed to know.
yes,
If at all you, then you have to say that patient does not have any complaint suggestive of increased level of diabetes. That's very difficult. So do not fall in controversy. That's what I wanted. Okay, now you can go. Madam, do you want to ask anything?
No, sir, I'm good. We
Okay,
can proceed.
go to examination.
yes. My differentials were uh, chronic limb ischemia due to atherosclerosis, acute limb ischemia, thromboangiitis obliterans, diabetic foot gangrene, or embolic arterial occlusion.
Justify each.
Sorry,
Yes,
madam, just a minute. I wanted to cut.
Sorry.
As the examiner has said, go to.
okay, sir. Okay, sir.
No, no, no. Now you cannot go
Okay,
back. This is what again a hint for exam. When examiner is favoring you, do not give him or her chance to answer. Now you'll have to answer madam's question. But that's a, you should have sent directly because avoided these controversies.
yes,
You
Absolutely.
understand? Because
yes,
that I did not like thrombogenic and the obliterans word. It no way it looks. It's female, 70 years, and everything like that. So that is, does not come in a picture. But
yes,
answer the madam. Justify each thing. Okay.
yes. Chronic limb ischemia due to atherosclerosis is appearing as the most probable diagnosis, as she is a 65-year-old female, uh, and there is a gradual progression of the disease, and there was no acute signs of pallor, pulselessness, paresthesia, and acute severe pain. So that is the most likely differential. Acute limb ischemia can
A
be a.
minute. You
Yes,
have forgotten that she is a known case of diabetic mellitus and hypertension, right?
yes, ma'am.
So are these predisposing factors to atherosclerosis?
Yes, ma'am. Yes,
So you have to add that.
yes, ma'am.
Okay, so this is not acute, but the second is acute limb ischemia, right?
Yes, ma'am. Uh, uh, as the
Chronic limb ischemia, it becomes acute limb ischemia, right?
sorry, ma'am.
From
I did
chronic
not.
limb ischemia due to atherosclerosis, second different DD becomes acute limb ischemia.
Due to a short history, uh, I have added that in the differentials, but considering her systemic factors of diabetes, hypertension, and no acute deterioration of her symptoms and blackening, it appears lower on the differentials. Thromboangiitis obliterans appears unlikely as the age is not in favor, and she is a female, and there is a lesser preponderance of female of age more than 40 years to get thromboangiitis obliterans. Diabetic foot gangrene is an unlikely differential, because there was no previous signs of paresthesia and neuropathy given by the patient, and no previous history of any similar complaints of reduced sensation in the leg. So diabetic foot gangrene is again unlikely.
Why are you giving so many diagnoses in differential then? From your history and examination, you should have come to one, right?
Yes, ma'am.
You are eliminating all the rest,
Yes,
but
ma'am.
yet you are giving this as one of your DDs, all of them. So, I,
Yeah, you are, madam, right. Similarly, what is difference between acute limb ischemia and embolic arterial occlusion? What is difference?
uh, the acute limb ischemia is, it can be due to some trauma, and embolic arterial occlusion is specific sudden embolic
Beta,
event.
embolic arterial occlusion is nothing but a variant of acute limb ischemia, as I have said.
Yes,
Right? From here, there are no evidence of acute limb ischemia. Your figure or photo itself is suggestive of. So you said, say, chronic limb ischemia. There is no doubt about it. Most likely due to atherosclerosis.
yes,
You understand? That
yes,
is the one. A remote possibility of acute thrombosis. Others are of no significance.
yes.
It is not a diabetic foot gangrene. Similarly, one more point I just missed is that you said there is no evidence of any foul smelling discharge. But is there evidence of foul smell? Did patient complain of foul smell?
No, sir.
Hmm?
No, sir.
Will she? Do you think you expected
In
in this patient? We are talking of this patient.
uh, if she's not complaining of the acute foul smell, then it's unlikely that it will be present on.
So did you find it in your examination part?
No, sir.
There was no foul smell.
No, sir.
So what is definition of gangrene? What is definition of gangrene?
the the death of tissue um, due to the lack of blood supply, the loss of blood supply.
Mhm. That's it. So again, you are poor in definition. You must learn certain basic definition. It's a macroscopic depth of the tissue. Macroscopic means you can see it. Microscopic is a slough.
Yes.
Without purification.
Hmm. With putrefaction. What is putrefaction? Invasion of the dead tissue by anaerobic microbe.
Yes.
Right?
Yes.
You can, so there will always be typical smell in a gangrene if you look properly. This is where putrefaction gland, which is typical, which we, my sir used to call a very specific name, sickly sweet. That means you smell typical to describe. Anyway, start with examination.
Yes.
Let's go.
The examination was done with due consent in a well-lit room. The patient was in a sitting position, holding her right leg with both hands. Patient was conscious, oriented, well oriented to time, place, and person at the time of examination. She's averagely built and nourished. There was no pallor, icterus, cyanosis, or clubbing. She was febrile. The pulse was 70 beats per minute, regular, normal force, and volume measured in right radial artery in the sitting position. The BP was measured in right brachial artery in sitting position and was 134 over 88 millimeters of mercury. The systemic examination S1 S2 normal, no murmur. Air entry equal on both sides on the respiratory examination. Per abdomen, it was non-tender, normal peristalsis. The CNS examination was she was conscious oriented. On local examination, on inspection, it was done in lying down position with the both legs side by side, while the left leg appeared normal. The right showed blackish discoloration of grade toe extending proximally 12 centimeters to 3 centimeters on the dorsal side and 10 centimeters by 2 centimeters on the plantar side, with medial foot black discoloration. The nail of the great toe appeared dark and brittle. There was a zone of hyperemia present around the blackening. There was a loss of subcutaneous fat. There was shiny skin over the dorsum of foot, and there was loss of hair over the skin. The rest of the right lower limb appeared normal. The Burgess postural test for pallor appeared at 30 degrees inclination. There was no oscillatory movement seen after the patient was put in sitting in a cross leg position. On palpation, the right leg felt cold.
Anything about the muscle wasting?
Sorry, ma'am.
Anything about the muscle wasting?
Ma'am, there was loss of subcutaneous tissue, but on comparing muscle both of the girth of the muscle below the tibial tuberosity, it was comparable, ma'am. Both was around 28 30 centimeters.
No, that is palpation, darling. Inspection, I'm talking about. See, you cannot have palpation. You have touched the patient. You don't touch the patient in inspection, right?
Yes, ma'am.
A- Was there any apparent muscle wasting?
No apparent
No,
muscle
right?
wasting was seen.
Continue.
Yes, ma'am. The right leg felt cold as compared to the left at the level of dorsum of the foot and chin of tibia. There was delayed capillary refill time. The tenderness around the gangrenous area and the loss of sensation over the gangrenous area. There was tenderness around the gangrenous area and there was loss of sensation over the gangrenous area. There was upset pulsations of the dorsalis pedis, anterior tibial and posterior tibial artery. The right popliteal artery pulse was palpable. The condition of arterial wall appeared normal and left lower limb peripheral pulses were normal on palpation.
Do you see first the normal side or do you see for the affected side first?
We see for the normal side first, ma'am.
Okay. So temperature, right? You saw the temperature?
Yes.
How do you see the temperature? Rise in temperature.
uh, by the dorsum of our fingers, ma'am.
Why not why not on the plantar? Why dorsum?
Ma'am, there is less amount of subcutaneous tissue at the dorsum, and there are more more uh, The nerves that detect the temperature are more so on the dorsal side. So we often check the temperature by the dorsum of our fingers.
So one basic question, Shizija, that in any case, why is the temperature the first and tenderness the first thing to be seen? In any case, irrelevant of this case, why?
Uh, because that is the first thing that we get on palpation of the patient. The first information that we get on palpation of the
Why?
patient.
Why do you do it knowingly that first I should see the temperature and tenderness. What if I do it later? What happens if you do it later?
Due to the maneuvers, the temperature might increase or falsely can be
You get
falsely
a false
raised.
tender. Yeah. Yes, that's the answer.
Yes,
Right. Because people fail if you do not say this temperature tenderness as the first thing, they fail.
yes,
They
ma'am.
might be very good student, but if they miss out on that, they fail.
Yes, ma'am.
Okay, Kshitija,
Yes,
good.
yes.
Carry on, Varun.
Yes, ma'am. The peripheral pulses in the right and left upper arms were normal. The bilateral carotid, facial, and temporal pulsations were normal.
Why upper arm only? Upper limb.
Lim,
Upper limb,
lim, lim.
upper
He's
limbs.
been
So,
correcting. He's been correcting you, huh? Twice.
Yes, ma'am. Sorry, sorry, sir. Um, the plantar reflex had a flexor response. The ankle flexion and extension against resistance were present, and knee flexion and extension against resistance were
what is
present.
that? What these three things, last three things?
Sir, they give the information that the muscles were functional, and
Mhm.
there is no loss of motor function of the patient.
So tell me what is difference between passive movement and active movement? Hmm? This is very chapter 2 of the Yes Das. Passive movement is what the patient does and you see. Active movement is what
Sorry, sir.
Sir
Sir,
is
your
muted.
voice breaking.
sorry, passive movement is what you do it, active is what the patient do.
Active is what
So
the
one
patient.
is in inspection, one is palpation. Sorry, madam, carry on. I have got a on.
Okay.
Can I?
Hello.
Yes, ma'am.
Yeah. Continue.
On auscultation, no bruit was heard. So my provisional diagnosis
When do
is
you hear a bruit, Kshitija?
uh, where the bruit is heard at a post-stenotic segment of the or of the plaque where
Very
there
good.
Hmm.
is.
So this is your provisional diagnosis or a summary.
Sorry, sir.
This is your provisional diagnosis or summary.
Sorry, sir.
What I
This
am
is
saying is you have
summary, sir.
written
Sorry, sir.
provisional diagnosis. So is it a provisional diagnosis or summary?
For composition.
Sorry, summary, sir. Sorry, sir.
Summary. That's why I asked. I thought it is summary.
Sorry, sir.
The
So where
big
is
one.
provisional diagnosis?
Just give
Uh,
us a provisional diagnosis.
this is a 65-year-old lady.
That is
Uh,
not. I am asking you provisional diagnosis.
Professional
65
diagnosis.
and everything has come in history.
yes.
Provisional diagnosis either two, three words or maximum one sentence. It cannot be beyond that. That is a diagnosis. This is not a composition, as Madam said.
Yes.
This 65 year is a diagnosis.
You have solved the case. Now tell us just the diagnosis. This is a diagnosis.
Uh,
Confidently tell us the diagnosis.
uh, right great toe. Uh, right grade toe gangrene in a case of atherosclerosis.
Your diagnosis is atherosclerosis. Again, sir has told you not to write chronic limb threatening ischemia.
Yes, ma'am.
Threatening should not be there.
Yes.
So this is atherosclerosis, right?
Yes,
Of
ma'am.
the
So
limb.
it's a left lower limb, or right, sorry, right lower limb atherosclerotic ischemia with gangrene of a foot. It is not only of toe, just for your completion.
Yes,
You
ma'am.
understand? So
Yes, ma'am.
that is your provision. Go back now to palpation part. But sorry, inspection. Back one slide. One is a burger spelling is wrong. Go back. Go further one slide. And how did you see this pallor at 30 degree? I would really love to see that, because till today I have not been able to demonstrate this test in Indian female or male.
In Indian skin. मेरा तो कभी नहीं देखी.
I have never seen in 40 years. So do not mention this. These are for the books and white limb persons. It is practically impossible to see this test, burgers, angles, burger exercise. That is for the book. If
Yes,
examiner asks you, you can straightway say, "Sir, I have tried, but I am unable to
yes,
demonstrate." It's
yes, ma'am.
not possible. What do
Yes.
you mean by that 30 degree? What do you mean by 30 degrees? Is it a good or bad?
It is bad, sir.
Acha, what is normal?
Normally, we can elevate our limbs up to 90 degrees, and then the pallor.
How will it help you? How will it help you?
So, the lesser the angle, the more critical the.
There is already gangrene. So now
Yes,
what more critical you want? You understand?
yes,
So each has its own role.
yes,
This is usually done when there is no gangrene. Evidence of ischemia is very minimum, and you want to see the viability of a limb in a healthy younger patients. There you have a role, and that was these all tests were done before the era of major investigation, when there was no Doppler, the only test which was your finger. In those cases, this could be of additional help. So do not mention them. Same thing goes for oscillatory. Why did you do that oscillatory movement?
um, sir, the.
Because book has written it. Don't do this. It
Yes,
is not needed,
yes.
and it can create a problem for you. Why there is a oscillatory movement, cross leg person? You won't be able to answer it, and then you are in real trouble.
Yes.
Have you really done this test? No, I know that you have not done it, because nobody does it, and it is not needed. So make it very precise.
Then they
No,
will ask you about vanishing popliteal artery.
yeah.
And then, what is guttering of veins?
Uh, Ma'am, when the emptied veins are visible, there is uh, a crevice in which the location of the vein can be traced. That is the guttering of veins.
Guttering, matlab, the veins are seen.
The veins are empty and collapsed, so the location of the veins
Okay.
appears as if it's in a crevice.
Okay. Thanks. So we'll go for investigation, sir. We'll go for management. Sir? Yes, Pankaj, sir.
So Radha, you can go ahead. I think he's busy on some phone.
हाँ सर तो आप आ जाइए. Can she go on investigation now?
He can go on.
Yeah.
Yes, ma'am. So a duplex scan was done, which showed that the right common femoral artery was patent with normal caliber and triphasic form. The superficial femoral artery was patent throughout, and
What
there
do
was
you mean by triphasic waveform?
ma'am, the triphasic waveform suggests that there is flow in the systolic, the diastolic, and the there is that there is flow in the systolic, early diastolic, and the late diastolic.
Okay,
phase.
then. Yeah, again. Continue.
Yes, ma'am. The superficial femoral artery was patent throughout, and mild diffuse atherosclerotic changes with biphasic waveform were seen. The popliteal artery had reduced peak systolic velocity and biphasic waveform. Anterior tibial artery was severely dampened, a monophasic flow, and distal segment was not visible. And posterior tibial artery and the dorsalis pedis artery had no detectable flow. The peroneal artery had low velocity and monophasic.
Okay. Next.
Sorry, I did wanted to ask something, but my phone came. Go back a little bit. Sorry.
Yes,
But I really wanted to clarify two or three things.
yes, sir.
Yes. Go one back.
Yes,
So
sir.
what did she answer about guttering of the vein?
She answered that when the veins are emptied on elevation,
Hmm.
then there is a crevice, and she said that is the
Okay.
guttering of vein.
Similarly, there is a delayed venous filling that you should mention rather than anything else. You understand? Delayed venous filling is important. How do you do that?
Uh, so the vein is emptied by putting two fingers, one at the proximal end nearer to the heart and one at the distal end. Uh, the proximal end is the proximal finger is traced more proximally, and then the whole vein is emptied, and then the distal finger, which is away from the heart, is released, and then
Okay.
we check.
What is normal venous filling time?
uh, Normal venous filling time is
Instant.
2 to 3.
Depends upon the length you have suppressed, but it is instant. You should remember. It will be delayed in case of because there is a more less blood goes, less blood come out. Similarly, you have written tenderness around gangrenous area. What is that? This is a very important point. That's why I went back, even though you had gone to Doppler. Sorry, madam, but I really wanted to
No, no,
clarify.
it's okay, sir. I thought the timing, they must be having some time, 9 to 10 or
I don't think
something.
so. Mathur sir, is there any time? Priya?
Continue
That is
till 30, but you can
yeah,
really
continue.
close by 10:20 so that 10 minutes we can give feedback.
Okay,
Yeah, that's
sure.
what I thought. There's a
I
time
thought,
restriction.
but just for so
Yes.
this is the one important point. We'll go after that. What is that?
uh, uh, there is tenderness around the gangrenous area.
So what is line of demarcation?
The line of demarcation is the line which separates the
Have
uh,
you seen? Is there a line of demarcation here?
so there is not a well formed
There is
line.
excellent line of demarcation. Go and see the photo.
Yes, sir.
Show us a photo.
Yes, there is nothing for more than that. This is a classical line of demarcation. This
Yes,
really I wanted to tell you. So, and there will be zone of hyperesthesia, not the loss of sensation.
yes.
You understand? It should be zone of hyperesthesia. There is a difference color. What is line of demarcation? Madam, continue. I will be just continue.
What is line of demarcation?
The line of demarcation is the separating line of the non-vitalized gangrenous tissue from the viable tissue.
What do you mean by tenderness around? How what is the significance of tenderness around the gangrenous area? What
uh,
does that
it
have to do with?
it can sometimes indicate that there is some infection that might be spreading, and the dry gangrene can convert to is in the process of conversion to a wet gangrene.
Okay, fine. Sure, let's proceed. Investigation. Let's go. Let's proceed towards the
uh,
Doppler is over, right? What
Ma'am,
else?
I have just the duplex scan of the patient, ma'am. That was the investigation that I had.
Okay. Next, what would you like to do on the patient?
uh,
Any other investigation have you done on this patient?
I would like to get a CT angiography done for this patient.
Okay. What about, is there something like a basic biochemistry examination, CBC, WBC
Yes,
count?
yes, ma'am.
Is it important?
Yes, ma'am.
Why?
So the complete blood count lets us know regarding the white blood cell counts. If there is raised, then there is some infection or inflammation in the system. The hemoglobin will let us know regarding the nutritional status of the patient, and if there is reduced
Yeah.
hemoglobin, then that
She's a
further
diabetic. She's a
increases.
diabetic.
Yes, ma'am.
She's a diabetic, right?
Yes, ma'am.
She's a diabetic. So you need to know the sugar.
Yes, ma'am.
Okay, next. Chalo. Okay.
Uh,
Have you shown us that picture how you palpated all the vessels?
Yes, madam. That is a good suggestion. You should have. We are
yes,
lacking the time. That's a different thing, but you should at least show that,
yes, sir.
right?
Yes, sir.
Are you sure? Because we are not live, so we are not there with you. See,
Hmm.
Ma'am, I could not follow the question, ma'am.
I'm telling. See, we are not there to examine you bedside examination, right? But you should have posted a
Yes, ma'am.
picture of the surface marking of all the pulsations. How
Yes,
did
ma'am.
you see the pulsation? Right?
Yes, ma'am.
A picture of all of them, right? Now, instead of that, we'll all have to go. What is the surface marking? Where did you feel the dorsal pedis? Where did you feel the you? So we need a photograph of all these pictures of all these palpation thing.
Yes, ma'am.
Did you understand, Shitija?
Yes, ma'am.
Yeah. So we don't know how you palpated it. Where did you palpate it? And that forms a major part of your examination.
Yes, ma'am.
You told us about the pulsations, right? The different pulsations, right?
Yes,
The
ma'am. Yes, ma'am.
palpable. They were dorsalis pedis
Was not palpable, ma'am.
and what else?
The dorsalis pedis, the anterior tibial and the posterior tibial were not palpable. The popliteal was
Okay.
palpable, ma'am.
Okay.
Oh,
What
popliteal
else
was
did you, what
palpable.
else did you palpate? What else did you palpate? That's very important. What else did you see for? I think you missed it.
The radial pulses and all the other peripheral pulses.
Besides the pulses, something else. There's something you missed. Are you supposed to know the movement of the joints, proximal and distal? Are you
Yes,
supposed to look for lymphadenopathy of that limb?
yes, ma'am. Yes, ma'am.
You missed it, right?
Sorry, ma'am. Yes, ma'am.
No, 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 sorry. Have you missed it, right?
Yes,
Sir,
ma'am.
is it relevant? Sir, किधर है?
Yes, ma'am.
Pankaj sir,
Yes, it is definitely. Actually, she tried to show that ankle flexors, and that was actually for a joint. But you should say that ankle joint movement normal or abnormal or absent, knee joint movement like that.
yes.
Clear cut mention should be there.
Yes.
And let's
Similarly,
note, sir.
lymphadenopathy will give you the idea whether there is acute infection is present or not.
Yes.
Don't miss
Similarly,
these things, huh, Kshitija. These are things which are very important. Though they
hmm,
sound very insignificant, they're very important.
Yes.
exactly, madam. One more point, yes, I wanted to say, do you always palpate anterior tibial artery? No. Why not? Because why we palpate dorsalis pedis and not the anterior tibial. Remember this point. Okay, books say anterior tibial, but normally it is not. The reason is it is in the there is no actual good bone behind it. One, it is overlapped by the tendon, so the direction is sometimes difficult to judge. Whereas the dorsalis pedis is typical before it goes into plantar surface between the first and second metatarsal space. You can palpate against either medial cuneiform or navicular. So that is the one more point you should know. No need to mention that each vessel you palpate against which bone. You are supposed to know that.
Yes.
It's an important point. Yes, ma'am.
Continue, Kshitija.
Yes, next.
Sir, this is the last investigation that I have. Uh,
Okay.
there is.
No, thank you. थोड़ी देरी है अभी.
Yes.
What would you like to know the patient?
Yes, ma'am.
अरे कंप्लेंट तो कर रहे आगे क्या करेगी पेशेंट को?
Yeah. Yes, ma'am. Yes, ma'am.
थैंक यू के वही तो बता रहा हूँ पेशेंट को अभी इतना करके थैंक यू बोल दोगे तो प्रॉब्लम हो जाएगा.
वो तो कैसे चलेगा हमको अभी तक तो कहानी बाकी है यार जल्दी जल्दी बोलो
Um, I would like to get.
Remember, very simple thing is being asked. You have done all investigation. Your diagnosis atherosclerosis.
Yes.
Rather, from the would you like to change after seeing the Doppler and your palpation? how will you explain that dorsalis popliteal is present in 70 years female atherosclerosis? It can be, but you should keep it so that you can revisit that it can be possibility of acute ischemia. Starting with that may be there. But anyway, this is your find. Now what will you do?
uh, I
Treatment.
would like to. Yes, ma'am.
Treatment.
Sorry, ma'am.
Treatment.
Treatment. Yes, ma'am. Uh, um, I would like to go ahead with revascularization process, as there is
What
uh,
is revascularization process? Can you
any
elaborate, please?
yes, ma'am. Any stenting of the uh, the
Did we talk about city or not?
No, no, she didn't. She didn't
So before
do. She
going
wanted to
any
do.
procedure in
She
70
wanted to
year
do, but
female, after Doppler, what will you like to do?
I would like to get a CT done, sir.
Which
But
city?
city
uh,
angio.
CT angio of the lower limbs, and
Which lower limb?
both of the lower limbs, sir.
Only lower limb. No aorta, no iliac.
And abdomen, na Puna.
Abdomen
Yes.
is must. That's what I initially
Inframedical.
said. The actual, is it possible that block may be in a iliac and popliteal is present?
Yes.
How?
Uh, because of collateral circulation
Good
due to.
collateral. So that is the one more point in Doppler you must see in it will be. So you should say CT angio of abdominal vessel and that. And then you
What
should go and read about MR also because
what is
nowadays, yes,
what
madam.
is the meaning of collateral? What are collaterals exactly?
uh, Due to chronic ischemia, there is development of uh,
One
valve
word. One word. Starting with S. These are chunks, right? They
shunts.
open
Yes,
up.
yes, ma'am.
They
Shunts.
open up.
Yes, ma'am.
Okay, fine.
Hmm.
Nature's way. Right, sir? Pankaj,
Yes,
sir?
sir. Yes, madam. Yes. So, okay, you have done CT angio and it suggests there is no block, up to popliteal, everything is fine. This is hypothetical. I don't know what CT actual angio is. Now, what will you do? This is the one scenario. There may be another scenario where there can be a block somewhere in femoral or iliac, and patient is saying both scenario you must mention. What will you do? And you should do not forget in say when you put a diagnosis of atherosclerosis, CT angio is a mandatory investigation. Whether you have done it or not, that's a different point. But
Yes,
you must speak about it.
yes, sir. So
And do
after.
not forget about diabetes, as Madam has said. Do not underestimate. It's an important point. Yes.
Yes, uh,
Okay.
yes, sir.
Something wrong with the audio, my audio.
Now the first point, patient doesn't have any block up loop popliteal. What will you do?
Uh, Sir, I would like to go ahead uh, with dilatation or
Tension.
stenting of the. Yes, ma'am. Dilatation
Huh,
or
go ahead, go ahead. Huh.
dilatation or stenting of the block beyond the popliteal to revascularize uh, the distal part, that is the anterior tibial and posterior tibial and the dorsalis pedis artery.
Mhm. How will it
If
help?
there is.
How will it help? Remember, any procedure which is invasive procedure on vessel, it can be bypass, it can be intraluminal, it can be anything else. What
Yes,
is the sole purpose of any procedure?
to increase the
No,
supply.
no, not increase. What
Salvage
is
the
it?
limb.
It's a limb salvage.
Salvage the limb, right?
What is meaning of salvage
Salvage the
surgery?
limb.
What is that?
uh, by doing the plasty or dilatation, we improve the blood supply to the limb and the
Hey, what did I ask you?
the
Limb salvage surgery. What is that? Salvage surgery.
um,
I'm not asking procedure. What will you do in limb salvage? What is limb salvage? The limb which can be saved.
Protected.
There is no evidence of major gangrene or a critical ischemia. Those patients are good for a limb salvage.
Surgery.
Do you think will you able to do limb salvage in this patient?
Yes, sir.
Okay, so what will you do to the gangrene?
Uh, a conservative raise amputation of the
Mhm.
great toe.
Okay, I would like to differ, but anyway, fine. What else? What is disadvantage of what you are saying, stenting or dilatation? So basically, when it is involving the moderate to major size vessel, limb salvage is easy and profitable, like iliac, aorta itself, or even in case of femoral and up to popliteal. Beyond that, doing any kind of limb salvage, people do it, but it is not much used. Keep this thing in mind.
Yes.
That's why I give you two scenario. In second scenario, obviously bypass or that is when you are planning this.
Intrafemoral has a good result.
Yeah. Okay, madam, would you like to ask? I think it's okay. We are done because we can go on
Uh,
type. Okay.
can you tell me last question?
Yes, ma'am.
Kshitija, is she there or she gone? Okay.
Yes. Yes,
Have
ma'am.
you heard of bypass? Have you heard of bypass surgeries? I mean, we use stent and this and that. In our olden days, we would do aorto femoral bypass and all. Have you heard of that?
Yes, ma'am.
So, what material, graft material do you use for that?
Ma'am, Dacron was the preferred graft material for the larger vessels.
Sir, is it right or is it
Yes,
PTFE,
yes.
sir?
There are multiple PTFE, Dacron, but those are the yes. Particularly for a major graph, it is always completely synthetic. In a
Synthetic.
smaller graph, you can
Okay.
have a
Can
both
use
combined.
the
PT,
P.
right?
Yes.
Okay.
Yes.
The last question, what is Leriche syndrome? Leriche syndrome.
Yeah.
Lerich syndrome.
Last
Due
question.
to an iliac thrombus, there is impotence seen in men.
What is the exact how do what type of thrombus it is? It's a word given to it. What shape?
Sad.
This is a big hint.
Third MBBS question.
The horse
Saddle, saddle.
saddle shaped. Yes, sir. Yes.
Saddle block. Okay.
Thank you so much,
Thank you.
sir.
Now
Thank
you
you so much.
give show me last slide.
Thank you, sir.
Okay. I think you have read more of a theory of treatment. So you are not well prepared for clinical examination.
Hello.
That was the only problem. But read more because in peripheral arterial disease, examiners are very particular about definition. This is the one condition when the definition matters. You should know all the definition. And second, what the madam has clearly said is properly palpating all the vessel.
Yes,
Do you
sir.
understand?
Yes, sir.
In exam, you will have to show. So you should know the right way to palpate. Thumb should be flex, tendon should be then just go lateral to it,
Yes.
trace it from the groove of metatarsal groove, come to the bone, and you are able to palpate. Because in a peripheral arterial disease, when you stamp absent pulsation, it should be really absent and not your failure of palpating. That is a difference between. That's why it is very important to palpate. Okay. Thank you. Priya, I think it's okay. Sir,
Sure, sure. I think
Yes,
thank
sir.
you so much, Dr. Pankaj and Radha, for conducting it so meticulously. I really appreciate your enthusiasm and the way you conduct. And I would like to say, Kshitija, I think what Pankaj Modi sir said and Radha said both are very right.
Yes, sir.
See, peripheral vascular disease has to be is like a mathematical mapping, you know. You
Yes.
have to be very clear what we are looking clinically.
Yes.
And see, history you could have shortened and come to a quick kind of an analysis, but examination, you have to really map it like mathematics, you know, which vessels are palpable, which are not palpable, which are weak, which are not weak. Because once you have that kind of a roadmap, your whole treatment is going to be based on that. And again, as Sir rightly said, acute on chronic versus chronic and gangrene versus non-gangrene. that clarity of thought for management has to come through your examination.
Yes.
So I think we should be remove all the rest of the thing. Okay, there's some echo, but doesn't matter. So this is what I thought. Otherwise, I think you have done fairly well, but I think more concentrate on your clinical detailed examination and that mapping. Sir, Dr. Mathur, I see. Do you want to add anything, sir?
No, I just want to ask one query to both the examiners
Hmm.
and to you also. Once the patient suffers from diabetes and hypertension,
Hmm.
it's a history of present illness. It's no more a past history. It's comorbidity which are persistent because
Yes.
both are uncurable. When we say past history means something which patient suffered and have been cured of it.
These are all, sir, comorbidities which we should not say
Yeah.
past.
So should it be mentioned past history or it should come as a part of that patient all
The
patient
part of
is
the
don't take
patient's
off.
disease, existing disease, sir.
Yeah,
You
existing
can,
disease. So,
this is part of the existing disease. You can only say whether it's controlled or not controlled or whether he has
yeah.
all that kind of thing.
So
You know
no,
what?
because these people always put it in the past history. Because past history for
No, no,
diabetes and hypertension. So I want to know clarification
no,
whether
no, no.
is
It's
it
not
right to
past
put in the
history
past
at all.
history or not.
We
I
used
would
to,
suggest, sir, diabetes is present, hypertension is a past.
why, sir, past? Actually, it is all his comorbidities. You
No,
know,
fine, agreed, sir. That is fine. But this is what the normally examiners think like that. That's what I am saying. We can
okay.
argue same thing where it goes for a tobacco. Because particularly if I am given choice, I will always include tobacco in a present
Yeah,
history,
yeah.
not in a personal history, like that.
See, tobacco is always present history because
Present
it is
history.
related to the disease.
Hmm.
Now, see, previously we used to all put this in personal history, diabetes and
Diabetes and
if you really see old K Das and S Das, they used to call it personal history. But I think we now should call it as these are comorbidities.
for
Because
Bombay,
of
yes.
that, I think these are all
Diabetes is definitely part of it. Yes.
diabetes is one, hypertension is also
Yeah.
part of the disease. You know? Like it has caused, I mean, whether atherosclerosis has caused hypertension or and cholesterol, we don't
Hmm.
know, but this is associated disease. You know?
Okay.
Sure.
Okay. Chaliye.
So
Thank you
thank
very
you,
much.
Kritija. You have any
Thank you,
questions you
Radha.
want to ask us, Kritija? Any queries which are unsolved in your mind?
uh, as previously in one of our Saturday lectures, we were discussing regarding the same thing. If the comorbidities is significant to the disease, then should it come in the part of history of presenting illness?
Yeah, I
Yes.
That
think if it
That's
is
what you say.
uncontrolled diabetes, then you should mention it in your presenting history.
Yes, sir.
If
Thank
like
you, sir.
patient has an infection of the foot and he says uncontrolled diabetes, then you should mention it much earlier. It should not come at the end of your history that he has uncontrolled diabetes.
Yes,
Uncontrolled disease has contributed to his infection. So I think it
yes,
should come much earlier in your thing. Like for a patient of uncontrolled hypertension has a bleeding and has got a stroke, then you should call it much earlier, no, rather than going at the end.
yes.
Okay.
Thank you, sir. Thank you, ma'am. Thank you, sir.
Thank you, all of you. I think such
Thank
a
you, sir.
wonderful evening. Thank you so much. Okay.
Yeah.
Thank you, Modi sir. Thank you, Radha madam.
Okay.
Good
Bye
night.
bye.
Good night to
Good night.
Good
everybody.
night, sir.